Hello, I'm Norman Swan. Welcome to this programme on acne, which is going out as a satellite broadcast over the Rural Health Education Foundation's satellite network. While acne affects almost all adolescent boys and most adolescent girls, it isn't necessarily a transient part of growing up. The condition may persist for years, affecting all ages. Those who are severely affected frequently encounter significant physical and emotional scarring, and it's that emotional scarring which is often missed or underestimated. And that has enormous implications for how you look after people with acne. Tonight, the latest evidence-based care and a few surprising new developments as well. As always, there are resources available on the Rural Health Education Foundation's website. That's rhef.com.au. Now let me introduce our panel to you. John Sullivan is a consultant dermatologist and Director of Research at the Skin and Cancer Foundation Australia. That's based in Darlinghurst, New South Wales. Welcome, John.
Thank you, Norman.
John Bell is a Principal Advisor of the Self-Care Programme at the Pharmaceutical Society of Australia, one of Australia's most respected pharmacists. Welcome, John.
Thank you, Norman.
Dr. Parker McGinn is a General Practitioner and Senior Lecturer in General Practice at the University of Newcastle. Welcome, Parker.
Hello.
And Neil Mann is Professor of Human Nutrition at RMIT University in Melbourne. Welcome.
Thanks, Norman.
And last but not least is Susie Hoytink, who's a registered nurse and the founder of the Clear Complexions Clinic, which is based in Canberra in the ACT. Welcome, Susie.
Thank you.
Welcome to you all. Susie, what's your story? You just didn't happen across a good business idea, did you?
No, I didn't. As you said, I am a registered nurse, and my interest in skin really started from when I was a teenager because I had acne, and I had that typical teenage acne, just like 85% of the population, and found very difficult to get some straight answers. So I went, like most people, to my GP, and I did do the course of antibiotics. I did a couple of courses, and sort of managed it throughout my teenage years, but I found it very difficult to get some advice on skincare.
How bad did it get?
It certainly didn't. I didn't feel like it needed to anything like Roaccutane. So because of that, I never went to a dermatologist. So it was about trying to manage it myself through what was available over-the-counter products and from advice from a GP.
What did it do to you psychologically and emotionally?
I'd just hid under a veil of makeup, as we all do. If, you know, it's lucky that I suppose we women can, but I think it just becomes a bit of a cycle where we make it worse. So very, very psychologically troubling when I was a teenager. And then when I came into my 20s, the hormones, it became more of a hormonal acne, so it definitely changed, became more around my jawline, much more difficult to cope with because in your 20s it should be well and truly over and done with. And it really persisted right through having children as well. And then in my 30s I just was sick and tired of it, and I think my search for answers led me to realise there's a lot of other treatments out there and a lot of very, very good skincare.
So have you applied an industrial sander to your face?
No.
I mean, from where I sit, it looks pretty smooth to me. So.
It's a lot better now, that's for sure. I still have to be a little bit careful. I still break out every now and then. If you've got acne-prone skin, you've pretty much always got acne-prone skin. But I certainly...
so apart from the industrial sander, what did you happen across?
We've really good, effective skincare. That was right for me because when you've got hormonal acne, and I'm sure get into this a lot more in detail, but with hormonal acne, the over-the-counter products aren't particularly appropriate for you. And certainly doing treatments such as I've done some peels on my skin and using some light-based therapies as well.
So tell me about these light-based therapies.
Well, it's a very different approach, I suppose, to the typical approach of applying creams and
So is this UV, or what is it?
No, it's not UV, it's LED technology, and it basically works on emitting a specific wavelength of light to achieve a result in the skin. So when we do, we use one called the Omnilux Medical, and we use a blue light therapy, and the blue light causes the P. acne bacteria to emit essentially to self-destruct by emitting a singlet.
They don't like blue. Pink's their colour.
No, absolutely. So the blue light kills depresses the amount of bacteria on the surface of the skin, and then we follow that with a red light, and what the red light does is it decreases the inflammation in the skin and also promotes wound healing. So putting those together, it's done in a course and it needs to be done, it's about client selection too, so you want to make sure that you've got the client right for that, but it's very, very good for hormonal acne.
And how long before you sort of pulled through what it did to your self-confidence and your psyche?
As soon as it starts getting better, you start feeling better about yourself. I think it's something that the moment you start seeing improvement, your whole outlook changes. It's an incredibly depressing disease.
And skincare? What sort of skincare tips have you got?
It's about it depends on the acne. So what is right for somebody in their teens is certainly not going to be right for somebody in their 30 plus age group. It totally depends on the individual, and that's where we come in with a little bit of guidance as to what wading through all that cosmetic confusion out there.
Right. So I don't need to change my makeup just yet.
Not just yet.
Yes, okay, welcome.
Yeah.
Parker, what do you think? Are you uncomfortable with this light therapy? Is it all mumbo jumbo, or do you think it's got something to it?
Sorry, excuse me. There's certainly science behind it, and light-based therapy has been shown to work, especially blue light and blue-red light, those wavelengths, working just the way Susie says by inhibiting the P. acnes in the skin.
But it's pretty expensive, John. So it's not.
I think, as you said, depending on the type of acne, benzoyl peroxide is going to be the cheapest and best option for many people, especially teenagers. But as Susie was saying, in the adult where you want that quick or good control, they've already spent a lot of money, it does work well. But for me, it won't be my first line, but it has been useful in a number of patients.
Because
I think, Norman, too, that whilst there is some evidence about light therapy, I think we should be cautious that our patients, our customers, our clients don't think that light therapy is UV therapy, because there's lots of those people with acne sit out in the sun thinking that sunlight and salt and all those things down by the beach are going to be the answer, and they're not.
It's probably one of the biggest myths apart from chocolate.
Probably.
Yeah, it's certainly a myth, and in the work we've done, it's certainly been a widespread perception that...
What other myths and misconceptions are there?
Well, certainly about chocolate being a cause.
Well, as we'll hear from the old man in a moment, it might not be entirely true about chocolate. There may be something to it.
No, sorry, we've got that right. But there are misperceptions about cleanliness being a cure for acne and dirt causing acne, and those misconceptions are actually quite important because they feed into over-vigorous cleansing of the skin, which can be damaging.
Yeah. And tons of Physahex being used on a 3 times a day basis. So is this just one disease, John?
And I think with acne, there are probably different types of people that, as sort of mentioned by Susie, the teenager is different to the adult, and there is probably increasingly a metabolic component too to a certain bunch of people with acne. And for the more severe acne, it's actually become more an inflammatory disease or an allergy to what's in the hair
follicles. So you think it's a different disease when it goes severe?
Well, in severe, there's something... It's all centred around the hair follicle, but it's how the body's reacting to what's happening there, that inflammatory component, and what drives that will be a mixture of things. It makes it a different disease to managing the mild or moderate.
So the response may be different. So take us through the basic pathology again.
Okay, so with acne, it starts during the adolescent years. You need those androgens around sort of puberty to come through, and the first thing is the pilosebaceous follicles make more sebum. And with that increase in sebum, there's a change in the keratinization or a formation of a keratin plug where the hair comes out. And there can be a number of other factors that can make that worse, such as soap irritation. We'll find out later about insulin resistance. And even sort of if you've got bad acne nearby, that'll actually promote comedogenesis nearby. So when the hair follicle blocks, there's a build-up of bacteria or P. acnes which digests and breaks down the sebum, and a lot of the sebum is made up with very pro-inflammatory things, and also from the bacteria, the Propionibacterium acnes, it produces a lot of pro-inflammatory agents as well. And normally that's contained nicely in the hair follicle, comes out to the skin without trouble, but if that follicle gets distended, it becomes leaky. Those things leak out into the dermis, and that's where you get those inflammatory lesions.
So you just might be a reactor.
And you might be just a reactor, and if you're a mild reactor, it's mild acne. If you're a severe reactor, you can get that scarring cystic acne. And
do we know if things like smoking make it worse? Do we know about the alcohol? I mean, alcohol flushing can make... What's the story here?
So I'd have to say, with cigarettes, it can cause a different type of trouble, that it reduces the support in adults. They can get those solar chemodones and makes the solar damage worse. But when it comes to acne, you can't blame cigarettes at the moment.
Damn it. Give me a little bit of the background to your research, Neil, because this will be a surprise for many people watching.
Well, first of all, I'm not a dermatologist or a clinician. I work in the area of nutrition, biochemistry, and for years we've, as a group, a number of international colleagues and I have been looking at aspects of human diet that have changed, i.e. the food composition we eat today, and the impact that has on our physiology and biochemistry. And we're particularly interested in insulin resistance and things driven by high carbohydrate diets that impact on diabetes. But we come across a connection to acne as well, and we started investigating that. So before
How did you come across that?
Mainly through our colleagues in the anthropology fields that we work with, reporting to us that the groups they study around the world don't show any acne while they're eating their normal hunter-gatherer type primitive diets. But as soon as they start a Western diet, they break out in acne, and it was usually associated, they said, with consumption of processed carbohydrate, starchy, sugary foods. So we started piecing the bits together.
Or it could be just a coincidence. The diet might not be anything to do with it. It might be something else.
Quite possibly, because all the medical books tell you it isn't.
Yes.
But that's another story. But we started piecing together the biochemistry of what could be going on. And we believe we come up with a very well-based hypothesis of what it might be. And then we tested that in a clinical trial and actually showed not only did we improve the acne condition as measured by dermatologists, but improved all those biochemical parameters we suspected.
Let's just have a look at what you found. So you actually studied insulin resistance. You looked at, you've got some graphs to show us. What did you find?
Yeah, if we can bring up that. Now this is not our work. This is the work we studied prior to designing our study, and we found a lot of studies had been done that gave clues to what was going on. And this one, for instance, shows what happens when you do an oral glucose tolerance test with young people, and you compare an age gender match group with acne and without acne. So not all people react the same. It really does depend to a certain extent on your genes.
So what happens when you do a glucose challenge on
well,
people
as this graph here shows, the two groups had virtually the same glucose response over the 2 hours, and people thought, well,
so at first
there's no difference.
There's nothing. Yes.
And then, if you measure the insulin response simultaneously, which is shown here, the group with acne always have a much higher insulin response. So it's showing that they're less insulin sensitive than the non-acne sufferers. So this started giving us clues that perhaps acne, like diabetes, is about insulin resistance. And
that changes through adolescence, doesn't it?
Oh, absolutely. Particularly during puberty, there's a drop in people's insulin sensitivity, as you can see in this slide here, in both males and females. So as your insulin sensitivity drops during those puberty years, we call that insulin resistance. So temporarily, you go through a period of insulin resistance as a teenager. Possibly because of growth hormones, we're not sure of the connection.
And why should... So again, that could still be coincidence. So what's the biological link then with acne, do you believe?
The next thing we discovered is there was work being done on a growth factor called IGF-1, which is insulin-like growth factor 1. And we found, much to our surprise, that this also peaks during puberty. And so we're putting all this together with other studies. We've observed studies on PCOS women, polycystic ovarian syndrome women who have severe acne. And some of the American studies were showing that the best thing that they responded to was metformin, which was increasing their insulin sensitivity.
So this is basically the drug for type 2 diabetes,
That's right.
foundation drug.
And their acne was going away. Similarly, they were treated with things like acarbose, which is an alpha-glucosidase inhibitor, which actually stops starches being digested in your intestine, so your blood sugar levels don't go up so quickly after a carbohydrate meal. And that actually helped their acne as well.
So how does the IGF affect, might be the...
Before we did the study, we spent several years putting all these pathways together, and we come up with this hypothesis, and this is our guiding hypothesis that we actually tested, that if you're insulin resistant, and these adolescent boys and girls mostly are, they're going to develop high hyperinsulinemia after a carbohydrate meal.
And by the way, this is independent of obesity, because there's plenty of thin kids who get acne.
Yep.
In fact, that's the stereotype, the thin, spotty kid.
We measure insulin resistance in many young boys and girls, and quite often it's the thin ones that have higher levels of insulin resistance, whereas in older people it's the overweight people. But if you look at this diagram, this is our hypothesis that once you eat a high carbohydrate load meal, you develop these high insulin levels that stay around most of the day because they keep grazing on these high carbohydrate foods all day.
Well, it's not just high carbohydrate, it's
anything with
high glycemic index.
Yes, anything with readily digestible starch, sugary materials and so on. Even a potato, it has quite a high GI, for instance. And what happens then, the high insulin levels drive up IGF-1. So the IGF-1 levels start to go up. part of that's due to just an inherent effect on IGF-1 production, but it also, insulin also drops the liver's production of IGF-BP1, the binding protein that usually incapacitates IGF-1. So you have more free IGF-1, and IGF-1 is one of those factors that John alluded to before, can actually block the pores in the skin. It causes the hyperkeratinization in the sebaceous gland, which actually blocks the follicle. And on the other side, you've got high insulin levels actually reduce another binding protein, which is a sex hormone binding globulin, which binds up androgen hormones. So you've got more of those free, so your FAI, your free androgen index, goes up. And these free androgens then stimulate sebum production in the skin. So you've got this dual effect. You've got the blocking of the gland and this overproduction of sebum, all being generated by high insulin levels and IGF-1.
And the acid test of this is a randomised trial to see if you intervene and you actually change the diet, you can get an effect. And you've done that in a small trial.
We did that with about 50 or 60 boys in a controlled study. And
how bad was their acne?
Very bad. These were people referred to us by our dermatology colleagues that had come off Roaccutane and other things for other reasons. And we recruited them into our study. It was a 3-month trial, so we had them for 3 months. We had some of the boys on a natural food type diet, low glycemic load, so it was lots of vegetables, fruit, low fat dairy foods, fish.
Just what adolescent boys love.
Yeah, and we cut out all the things like the pastries and the donuts and the sugary drinks, and the other group ate their normal diet, and we saw quite a big difference in the biochemistry of what was going on with IGF-1 and the binding hormones in that group that was quite protective then of acne, and their acne scores dropped substantially.
Hard though to maintain in adolescence?
Yes, it's very hard to get adolescent boys, free living boys, they're living at home, even with their parents involved, to actually stick to that sort of diet. So we did
no adolescents free, by the way.
True. We did provide a lot of their foods to make sure they ate the right things. We corresponded with their parents, and I had 2 lovely PhD girls who controlled the boys very well and got them to eat the right things.
Yes, well, they can't be around forever either. So here we have a situation with different diseases, different routes to the same problem, and then reactions and the influence of lifestyle as well. So this is the background, and presumably, John Bell, you see people coming into your pharmacy with the same myths and misconceptions, buying the wrong stuff over the counter.
We do, Norman. Often they're predisposed towards purchasing something not only from the pharmacy but from other outlets by advertising, and there's a lot of that.
And you've even got high glycemic foods by the counter as well.
Well, some of us do, not all pharmacies. We've gone in for the lower GI products these days. But having said that, as Parker was saying, there's inherently, I think, a concern that it's poor hygiene that maybe causes acne, or at least is one of the causes, and therefore there's sometimes an obsession with abrasive scrubs to clean the face. There's certainly a concern about food, but maybe the wrong food. I'm not too sure whether Neil answered the question about chocolate. I guess we can get low GI chocolate, can't we?
Yeah, that's right. Chocolate's not really a high GI food. It's moderate.
Yes.
There's worse things in chocolates. I'd take them off white bread and potatoes before chocolate.
So we've got a question from Central Queensland, a general practitioner in Central Queensland, asking about ethnic differences here. Is this the story that Neil's been giving us, or are there true ethnic differences? Because you know, there's a sense that people from South Asia tend to be afflicted with acne worse than other ethnic groups.
And I think the answer to that question, I think westernisation has changed sort of people's type of acne from the country of origin versus, say, in Western countries like Australia. And often you'll have patients where there's no family history of severe cystic acne or scarring acne. They come to Australia from China, from Vietnam, and suddenly they've got scarring acne. And you know, something has changed, and whether it's just diet, stress, or other bits, we'll discuss that bit there. But I thought one other sort of interesting bit is, even say with Aboriginals whose diet is probably no longer low GI in many ways, that's one group where, when our college has done studies looking at the prevalence of acne and severe scarring acne, it's actually not seen anywhere near the same proportion as in other groups. So there are some
complex
sort of
interactions. Can you predict who's going to progress to severe acne?
So I think there's sort of a few warning signs where it's more likely. So someone's got a family history of severe cystic or scarring acne, if one of the parents has scars from their acne, you've got to be very careful in managing those children that they might have quite rapidly progressive acne that will result quickly in scars. So sometimes those deep, tender nodules that have come up quite quickly, especially with that family history, or the type of acne where they had mild acne as a teenager, but when they hit their 19s, 20s or early 20s, suddenly their acne comes back and
blows up.
And that can be sort of the more aggressive type.
Let's go to our first case study, who's Ramesha. Ramesha is a 14-year-old girl, Sri Lankan descent. She's had nodular cystic acne for the last year or so. Her father's had bad acne and now has severe scarring. Let's see a picture of Ramesha, or a child like Ramesha. Parker, she's your patient.
So she's a 14-year-old girl, so she's quite young to have acne of that severity. We're also told she has nodular cystic acne. She's certainly got inflammatory acne there, and we're told that it's nodular cystic. It's often, if you get up close, it's often better to appreciate that. In those circumstances, it'd be very reasonable to start her on treatment, but you're especially alerted by her father's history. A parent or another first-degree relative who's had scarring acne alerts you to that she's in danger of scarring. So it'd also be reasonable to organise her to see a dermatologist for assessment.
What would you do for her? Apart from the referral?
It'd be quite reasonable to go through the whole situation, her situation, find out her circumstances, and look at all those kind of things we're talking about, her perception of acne. But with her, she really needs treatment as well as sorting that out. So it'd be quite reasonable to start her on an oral antibiotic and topical treatment, but to organise, to get on the phone and organise an appointment with a dermatologist for her.
If she'd come into the pharmacy looking like that, what would you have done?
We'd refer her to her GP immediately, Norman. Yes, I think
start messing around.
No. That's not the kind of patient that we would feel comfortable recommending a non-prescription product for.
So she comes to you, John. What do you do?
So I think the good part is hopefully we get to see her early, and the important part in this lady is preventing her acne having an impact on her at that young age and that crucial phase of development, but also later to prevent the scars. That the scars of acne can really sort of affect people's sort of self-confidence, their interpersonal relationships, and even reduce their risks of getting certain jobs, going for certain careers. So,
I mean, Susie, she'll already be feeling bad about herself at the age of 14.
It can be devastating, absolutely. Yep.
And it's quite bad. So what would you do?
I think with this lady, I would be sort of quite aggressive in the treatment. That there's warning signs, as mentioned by Parker, that she's going to be at great risk of scarring. So if the antibiotics have worked really well, and often that lag phase of a few months to see the dermatologist.
So is there evidence that antibiotics help?
Yes, no, there is good evidence they work, and often they can work well, and especially that sort of inflammatory sort of acne.
Do they need to be oral?
And for the face, actually, topical products are at least as effective as the oral antibiotics. So some of the newer combination products which combine benzoyl peroxide and an antibiotic are at least as effective as an oral antibiotic. So often I'll reach for those first before going for a systemic agent, in that there are a lot more controversies regarding oral antibiotics.
So antibiotics, benzoyl peroxide or salicylic acid? What's the story here?
So I think if someone's on an oral antibiotic or an antibiotic, it is actually very good to combine it with either benzoyl peroxide or salicylic acid, because that actually helps reduce the risk of resistance. That both salicylic acid and benzoyl peroxide have antimicrobial activities. They open the hair follicle and make it unfriendly to the bacteria as well. So actually, anyone I'm putting on an oral antibiotic, I'll still try and push one of those options as well. And so if people have very sensitive skin, I'd probably go more towards salicylic acid, whereas people with more the teenage skin, the benzoyl peroxide's a good way to go.
John, would you start this young lady off on a combination topical, or would you begin with a retinoid or benzoyl peroxide? Would you go straight to the combination?
And I think with this lady, if she's quite young and her acne is rapidly getting worse, I'd actually be sort of, if the oral antibiotic's not working well, I'd actually be probably looking towards Roaccutane if she came back a bit later and she really wasn't getting better or not significant improvement.
You would give her an oral antibiotic from the start?
And I think it's always good to give it a go, because sometimes it might settle down and actually sort of clear with that oral antibiotic, and it might be good for a while.
So I'm not getting it clear here. So she might have come to you from Parker on an oral antibiotic, but you might change to a topical antibiotic benzoyl peroxide combination.
Actually, no, I must admit, in this lady, I'd actually have a low threshold to put on Roaccutane, thinking it's good to turn it off, clear up the acne and prevent those scars.
So you jump in early here.
I would sort of...
and what are the current criteria for the prescribing of Roaccutane?
And Roaccutane sort of prescribed, or isotretinoin, when sort of other agents are failing or not doing well. And traditionally it had meant an oral antibiotic, but my interpretation now is that you can have one of those combination topical products which work just as well. So it's good to try one or two things first.
And it's still a dermatologist-only prescription?
But I suppose in country or rural areas there will be other sort of doctors or paediatricians sort of accredited for prescribing Roaccutane or isotretinoin.
So what's the shtick here? What's the informed consent? What do you have to do? This child will have to go on the pill, won't she, if she's menstruating?
And I think at the age of 14 it needs to be definitely very well discussed, and the oral contraceptive would be a preferred agent. There are a number of issues with oral contraceptive, but sort of going through studies, say in Western Sydney, the risk of a 13 or 14-year-old being sexually active may be up to sort of 28 or 32%. So that issue needs to be addressed, and preferably want them stabilised on the pill for 2 cycles before considering Roaccutane.
And could the pill help her acne?
And the pill can work well for acne. It unfortunately takes 3 to 6 months to kick in, but the pill actually can work for quite severe acne.
All pills or just some?
So the cheaper sort of older agents with high dose Levon or Gestrel tend to sort of worsen acne unless someone's got an irregular cycle, and just regulating that cycle can be useful. Then there's sort of the most effective pill traditionally been the ciproterone acetate containing pills, which unfortunately they sort of take a while to work. They're the ones that go most with weight gain, mood change, and probably have the highest sort of risk of clots and that. So nowadays the newer but more expensive contraceptives containing drospirenone or Dinogests such as Valet, Yaz or Yasmin are probably the most effective ones for reaching to with the lower doses.
John Bell, this can be an expensive process for people, the treatment of acne, because it's not all covered.
It's not all covered at all, Norman, no. And I mean, the products that John's been talking about, the topicals, are not PBS subsidised. The Roaccutane is, provided there's an authority, of course. But we're looking at maybe between $30 and $50 for a course of treatment, which could last for a couple of months nonetheless. Maybe not too different, not so much more anyway than a PBS prescription, but for a concession card holder there is a significant difference in cost. So that needs to be discussed, obviously.
So what I'm hearing here, the message here with Ramesha is you're not going to mess around, you're going to get in early.
And I think especially...
So the parents say they've read awful things about your Roaccutane. Children commit suicide, your skin peels, you get headaches. What is the story with the side effects and complications of Roaccutane?
And I think it still remains our most effective medication for acne, and it doesn't work for everyone, but it sort of works in all types of acne, and it works best for the more severe or cystic and scarring acne that, for the mild acne, it'll clear it up, but unfortunately you don't get the remission. But in this sort of patient, she's one of the type of patients most likely with 1 or 2 courses to be cured of her acne.
What's a course? How long's a course?
So in the past it used to be high dose over 4 months, but these days we generally go a bit slower, a bit more gently, and do it over sort of 7 or 8 months on average for a dermatologist. And that way it's not quite as harsh on the body, their skin doesn't dry out, they're not at risk of their hair falling out, or they get used to putting on moisturiser and things like that. So these days we are a bit more cautious, and starting at a lower dose you're a bit more likely not to get a bad flare. But I think the big controversies with Roaccutane, that just telling someone that it can cause birth defects can really sort of worry the whole family. This is pretty toxic. But fortunately it's just really a high dose of vitamin A. It's out of your body in sort of 5 days from stopping it, but if someone does get pregnant on Roaccutane, it is a disaster, and that usually does mean an abortion, which comes with many concerns like later depression and maybe trouble with fertility even. But I think the big thing, I suppose, with the controversies of Roaccutane, which have been useful to highlight the issues with acne, is just the controversies regarding mood and depression. That acne itself can really get people down. It is associated with depression and even a higher suicide rate. And I think sort of if people do any sort of search on the internet with Roaccutane, it will highlight there have been some people who on taking Roaccutane have got depressed or even committed suicide. And I think reassuring when you look at the cases, there have always been multiple factors involved, and hopefully a lot of areas where intervention could have been done. But I think the important part in anyone with bad acne is sort of warning both that patient and the parents what are the signs of depression.
So do you ever send off a child like this for cognitive behavioural therapy to see a psychologist to help them through psychologically?
And I think when you sort of talk about these patients with psychiatrists, and that if their acne is a big reason for their depression, most people are going to say treat their acne, and that's going to make a big difference. But I think it's those patients where they do feel down for no reason, or do go flat or stop doing the things they're doing.
So you want to assess their psychological state.
So I think it's something...
Parker, you wanted to say something?
It's worthwhile restating that you might go online to the internet and find a whole lot of evidence for the effect of ostretinoin on suicide and depression. But in fact, if you do a Medline search, there's no evidence. It's all anecdotal stories. What evidence we have is there's nothing linking ostretinoin to depression or to suicide. It's biologically plausible, and it may be that it's a rare idiosyncratic reaction, but that's only anecdotal. What we do know is that studies have shown that treating patients with Roaccutane actually makes their depression better. So there may be rare idiosyncratic cases, but it's not something that should stop us or should have parents concerned about their kids.
Susie?
Absolutely, but with Roaccutane too, I think it's something that there's a lot of information out there, as you said, that certainly makes people very wary and very cautious of it. But in the right client, with the right patient, if they need Roaccutane, that's the only thing that's going to help their acne. So that real severe nodular cystic acne, that with risk of scarring, there really is no other option.
And some people believe that the light therapy can modify the flare.
I think actually, with the Roaccutane, one of the risks is you can get a bad flare before you then improve, and that sort of patient, I'll start concurrent antibiotics, but I've actually found the light treatment really good to help prevent that. And
so we've got a few questions coming in. A nurse from Rockhampton asks, what validity is there for some of these home remedies? Toothpaste on pimples, hot flannel to draw out the pus, yum yum, sulphur to dry it out, extraction of blackheads at the local beauty salon. Susie, anything to any of these? Well,
you've got to be very careful. Anyone who says that we often get clients in and we say, do you pick at them? And they say, no, we definitely don't. But in truth, almost everybody does. So it's all about client education or patient education, making sure you get to the heart of the matter with it.
So popping the pluke, as we used to say in Glasgow, is not a good idea.
Not a good idea at all, but they're definitely going to do it. So it's a way of making sure that you give them the information on, there's all sorts of little devices, little easy squeezes and things like that out there. Generally,
steer clear.
We try and tell our clients.
The hot flannel seems to be a nice idea.
I suppose it softens it up a little bit. I don't know that there's a whole lot of evidence that would help that at all. And as far as toothpaste goes, that's a new one on me.
It depends which sort.
Yeah, it does.
Yes. Rural Victorian general practitioner, how is acne best looked after in pregnancy? John Sullivan?
Okay, so with pregnancy, often actually 1 or 2 babies are very good for the long-term improvement in acne. And that might be one reason why hormonal acne and female acne has become more of an issue. And during pregnancy, often the first trimester acne gets worse, second trimester starts to improve and hopefully clears during the third trimester. So it's just that first period that it's usually an issue. So my favourite sort of ones are sticking to what is very safe, and I'll start with the topical agents, and that's things such as the benzoyl peroxide, clindamycin, or combination of the two, such as Duac. And so if it's more widespread, erythromycin is really the only sort of systemic oral treatment I'd use. But I'd have to say...
Salicylic acid's okay?
And salicylic acid, at least not in a large amount. So if you're doing a widespread area, I'd say no, but just for the face, the 2% products would be okay. And this would be one area where, I do actually think the light treatment's another good option if those things are failing, that the light treatment can be very good sort of short term to get good control.
Yeah, but we don't do it when they're pregnant.
And that's the laser or light or...
No, the LED, all light-based therapies we don't do when they're pregnant. So it's very difficult.
Just playing safe, yeah.
Just playing safe.
And generally, playing safe. And generally, they don't really want to use anything at all anyway, even
mind
the over-the-counter
low glycemic index diet would be all right with your pregnant?
Probably, but I tend to err on the safe side and not try to interfere in pregnancy situations at all. I think women and their diet is up to them. They're under enough stress at that point.
Yes, Norman, I was going to say, although erythromycin is obviously the best choice in terms of an oral antibiotic, I mean, we wouldn't use a tetracycline. The estolate, erythromycin estolate, is not suitable for a pregnant woman. It's likely to cause cholestatic jaundice, so we use the erythromycin base.
Good. That was a good question, so thank you for that question. A nurse in Central New South Wales asks, a patient of hers has PCOS, polycystic ovarian syndrome and complains of excess oily skin before her periods. Does the build-up of this oily skin inflame acne? Should she blot the oily skin?
Well, so there are a few questions there. So unfortunately, people with that oily or seborrheic skin, they're more likely to have that persistent and ongoing acne, and they're one of the ones that won't do well with Roaccutane, and they're ones where you're going to have to really do that long-term strategy. I think I'd definitely look at the low GI diet as much as you can there. With someone who's, say, overweight and polycystic ovaries, that's where metformin's a good option, and that can kick in.
And might help the
oiliness. So after 3 or 6 months, that can kick in. And unfortunately, in that situation, often the oral contraceptive pill doesn't work that well for it. And I think something like the benzoyl peroxide is not bad because it dries out the skin and will get rid of some of that oiliness. And usually in an adult, the skin can be quite sensitive, but that sort of patient usually will tolerate benzoyl peroxide well.
And just make sure she's using white towels, not coloured ones for the benzoyl peroxide. Linda in Wagga asks, how do we convert the findings from Neil Mann's research on diet and acne to effective health promotion or patient education? Parker?
I think that's a really good question because Neil's study was done in people with really quite severe acne, and that's not the kind of people that we see most of the time. And normally we're very careful about extrapolating those results to our patients, but in this case I think it's a no contest. What we're advocating is basically something that may well help them, even though it hasn't been shown in this particular group. It's likely to help them. And it will do a whole lot of other good things for them. So there's no doubt that you really should be encouraging it. The question is, how can you convey to your patient the benefits? So some patients will be so motivated because of their acne that they're going to adopt really what's a fairly strict diet, which is what you're going to need if you're doing what Neil did. Some kids probably aren't that keen on it. So again, it's a matter for negotiation, but I think it's a no contest. You really should be trying to stress that.
Yep. And Neil, we don't know about exercise because exercise can change your insulin resistance.
It could, but our study didn't involve exercise. Being a clinical controlled study, we have to keep everything constant except the one thing we're trying to experiment with. So we don't know the answer to that. But just to reiterate what Parker said, it's a type of dietary approach that's not going to do any harm. We got all sorts of other improvements in these young people as well, including lowered triglyceride, lowered cholesterol. They met their RDIs for all their micronutrients much better than they did on their previous diet. So it's a win-win all round, even if their acne isn't cured. There's a lot of other health benefits.
Another question from Michael in Cairns asks, does humidity have any effect on acne? In other words, the further north you go in Queensland, does it get better?
Okay, so there's definitely...
Michael should know the answer to that, he comes from Cairns.
Okay, so I suppose there's definitely sort of a tropical acne, so when you get to the extremes, just the edema, and that can sort of help contribute to blocking of the hair follicles there. Other bits can be sort of sweating, friction, and that can cause acne in other places, like on the back and that there. But I think the big thing with, say, the difference in humidity would just really change what sort of topicals you choose, and also sunscreens and other sort of skincare products. So in that sort of patient, they've already got sort of quite sweaty, moist sort of skin, so you're definitely not going to be using heavy products. You're going to be having very light sunscreens, gels and that. And often it might be the heavy occlusive sunscreens or irritant sunscreens that can bring out acne in that situation.
And that's what you spend a lot of time advising people on, Susie.
Yeah, definitely. So generally sunscreen is something that most people with acne tend to avoid because they've just got this misconception that it's going to clog their pores, and yet it's very important, obviously, with our sun here, that we obviously need to protect our skin, but even more so if you're suffering from acne, because as your skin's healing from a lesion, it's very prone to damage from UVA and UVB, from collagen and elastin destruction. So you definitely need to protect that, but using something like a physical blocker like a zinc, which is very calming and anti-inflammatory, is good, but again in a humid environment can be a little bit clogging. So if you can get something, as I say, in a gel, is fantastic
and
for a
humid
humid
environment. Now one of the better sort of sprays or lotions or gels actually owned by the J&J, that Helioplex has the best UVB, UVA protection. It's very photostable, great if people are on Roaccutane, tetracyclines, but it won't clog the pores and it's not irritant, so that actually is probably the best one.
Ask your friendly pharmacist for those gel preparations.
Absolutely, Norman.
Let's go to our second case study, who's Diane, 17 years old, rural New South Wales, presents to Parker, her general practitioner. She has open and closed comedones with early evidence of inflammation. Her naturopath recommended a liver cleansing diet to reduce toxins throughout the body, and she's stuck at that for 7 days, but she thinks she'd better come along for some advice. When you ask her, Parker, she tells you she washes her face 3 times a day, and she's pretty well made up when she comes to see you.
That's not an unusual situation. 2 things there. One is a situation Susie's described earlier of trying to hide behind the makeup, and it can actually be making things worse. The second thing is, again, is that the face cleansing. A particular concern there is not just how often she's cleaning, but what with and how vigorously she's abrading her. This is an inflammatory condition. If you go abrading it, it's going to make it worse. So I think the first, and also a liver cleansing diet is not something that's been shown to work with acne, and there are things that have been shown to work. So I think we need to gently go through her perceptions and talk through her about how her approach to this is going to be. And that's going to involve...
Although, Neil, it's not very high glycemic index, so in fact you eat almost nothing. I mean,
yeah. And look, as a physiologist and biochemist, I'm very sceptical about liver cleansing diets. There's no real proven result at a biochemical level, but it could inadvertently be doing some good, because that type of diet does tend to be very low glycemic index, low glycemic load. So you might be getting some improvement,
but it might be
for the wrong reason.
Yeah, and too restrictive.
Yeah.
But anyway, sorry about Harker, interrupted.
No, I think that's important, because some kids do come in on quite restrictive diets for through misconceptions that they've abolished milk products, so their calcium intake is suboptimal. So I think it's important to go through it and to talk about, use Neil's study as an example that actually...
there is a way of eating which helps.
There is a way of eating that is good for your acne as well as the rest of your body. But the other thing with her is to go through that and negotiate that. And it depends on her priorities and how fast she wants you to be working on this. Given some of the hints we've got there, she may be keen for you to get cracking straight away and be giving her medication. I think the first thing is to stop the things that are actually making things worse.
So let's just, John, let's have a look at some pictures of grades of acne and just see where Diane may sit on this.
Okay, so with Diane, she'll fall somewhere between these two, the grade 1 and grade 2 acne. So with the grade 1 there, you've got the comedonal or relatively non-inflammatory, where you've just got the blackheads and or some whiteheads. And it's the whiteheads largely that progress to the inflammatory ones there, but as you can see, there's a mixture of whiteheads and blackheads causing the inflammatory lesions on the right. And the big thing for patients, I mean, they will notice the blackheads, but the inflammatory lesions can fluctuate quite a bit, and they're the ones that are most noticeable. So that's the sort of thing that you want to try and control and prevent. And fortunately, for this sort of acne, the topical and good skincare can make quite a big difference.
Before we get on to Diane's management, let's just go to the more severe grades of acne, just to remind ourselves what it looked like.
Okay, and as acne sort of gets worse with severity, it's number one, it can involve a bigger area, so extending from the face onto the shoulders, maybe onto the chest, back, and for the more severe, down to the thighs. And then it can be just the lesion count, so a few comedones through to a lot more, but really the severity of acne is mostly to do with the severity of inflammation. So as acne gets more severe, you go from sort of small, slightly inflammatory red papules to ones with sort of pustules, right through to cysts and nodules, and then you can get these quite complex sort of scarring and inflammatory changes, as in the grade 4 there.
So, Parker, she might be pretty psychologically knocked about with her acne, but it doesn't have the urgency necessarily of Ramesh's condition medically.
Medically, it doesn't have anywhere near the urgency, and providing psychologically she's okay. I think you can start talking about using topical medications with inflammatory things like that. There's a choice. You'll probably find that she's probably already used benzoyl peroxide over the counter, so you can find out if that helped. Is that something she's going to continue with? Are you going to add in a retinoid, a topical retinoid, etc.?
So how do you decide, for instance, about salicylic acid? Because that can be quite effective.
Yep, salicylic acid is an option, and that could be used as first line as well.
What strength?
I think it's 2%.
Just 2% larger, yep.
So the key here, John, is that it stays on. You've got to prescribe something that stays on.
I think when you look at the studies looking at the cleansers, if they're going to do something, it's fairly minimal and not a big difference. So the most effective products are the leave-on products. And
so what are the formulations, John Bell, that we look for there for stay on salicylic acid, stay on peroxide, benzoyl peroxide?
Well, as John mentioned, there are washes containing salicylic acid and benzoyl peroxide, which are probably not going to do any much more, and maybe even counterproductive in terms of the other option, which would be a gentle non-SAPI cleanser, something like QV wash or Cetaphil. In terms of the stay-on products, well, benzoyl peroxide begins at 2.5% and goes up to 10%. But there's no evidence that the 10% product is any more effective than the 5%, but it's certainly more irritating.
But you can get creams, you can get gels. What's the technology here?
Sure. The gel for really oily skin would be much more suitable. If the skin tends to be very dry, then the cream would be satisfactory. But benzoyl peroxide is generally in a gel. Some of the prescription products, like adapalene, is available in a gel and a cream.
That's the retinoid?
That's right. It's one of the retinoids, yeah. But
and is there any evidence that that's any better than tretinoin?
No, I think that they're probably much of a muchness, and I think it's just a matter of what a GP or a specialist would have a personal preference for.
So I'm actually confused. Give me a protocol here. I want a protocol. And something that's systematic, because I think the risk here as a general practitioner is you do what the patient does, a little bit of this and a little bit of that, and you're not systematic about how you approach this. What's the systematic way? Do I start with benzoyl peroxide? Do I start with salicylic acid? How long do I go for? Do I escalate the dose? What's the advice here? Give me concrete protocols here, Dr. Sullivan.
So I think for this lady, if her acne is mild, as suggested there, my choice between salicylic acid or benzoyl peroxide would be if she's got sensitive skin or easily irritated skin, I go for the salicylic acid. But if it's more oily skin and she's had no trouble with eczema, either one would be okay, and I'd probably reach for the benzoyl peroxide. And
in what formulation?
And so as mentioned, I wouldn't go for the 10% or even 5%. I'd usually sort of be around the 4 or 5% with the benzoyl peroxide.
And how many times a day?
And usually I'll just sort of start once a day. That once you get up to twice a day, there's more of a risk of irritation, patients getting frustrated and giving up on the treatment. So it's always better to start slow. And I always sort of think if once a day benzoyl peroxide isn't working well enough, I'll be looking to maybe seeing a GP about what would be the next option there.
You could use alternate nights to begin with too, couldn't you, John? Just for the first week or so.
Yep. And especially if sensitive skin, start second nightly, and as you said, be careful with your white towels.
And how long are you going to wait before you escalate? Before you escalate this, if it's not being helped?
It's going to take longer to actually have maximal effect, but if you're not seeing some effect in 4 to 6 weeks, it's reasonable to go up the next step. And
what's the next step? The protocol.
Well, I mean, there is a step type approach in the dermatology therapeutic guidelines, which is topicals. This current set, they've changed and had retinoids as the first line, and then second line topicals, topical antibiotics and benzoyl peroxide.
So they'd start a combination benzoyl peroxide retinoid earlier on?
No, they'd start with a retinoid, and then if you're not getting control, add the morning topical antibiotic or topical benzoyl peroxide to the evening retinoid. I think that's a little bit sort of probably not practical in that everyone's already used benzoyl peroxide before they get to you, and so I think that there's flexibility to talk through those options with the patient.
And how do you approach this? Because this would be the sort of typical person you would see, Susie.
Yeah, excuse me, it certainly would be. So first thing we would do is make sure they've seen their GP. So because with a client like this, we often want them to talk to their GP about possibly talking to them about the oral contraceptive pill as well. That is an option, although I understand that it does take quite a bit of time before that they see the effect of that, but that's often the first point. We like to break it down to what are you doing every day? So what are they washing their skin with? Are they using sunscreens? Are they using moisturisers? The thing about starting on the retinoids, I think, is compliance with the client or with the patient. It makes the skin quite red and irritated when you first start using them, and in this age group they're often going to stop. because anything that they perceive as making it worse, they're going to stop straight away. So just making sure that you can give them an appropriate moisturiser to counteract the fact that they are very dry,
and what is
very
an appropriate
red.
moisturiser?
Oh, something that's very light. Sometimes a lotion rather than a cream is better. So that's something where we often give advice on those sort of things. And also, again, this young girl, is coming with her mum. And she's wearing some quite thick makeup, so that's something that we, again...
So heavy foundation.
Yeah,
What do you recommend for makeup?
Look, I mean, it's the lesser of all the evils, I think. We usually recommend a pure mineral makeup. It's
That's
less
that powder
clogging.
stuff.
It is powder, but it doesn't contain talc, and talc is a very refined powder that sits in the hair follicle. So usually contains zinc and titanium dioxide, sits on the surface of the skin a little bit better. Most clients see almost within a couple of weeks a change in their skin, less comedones because of that, less inflammation because of that.
So ideally it's no makeup, but if you've got to wear it.
It's unrealistic.
Yeah.
It's just so unrealistic because you've got to make sure that this young girl feels good about herself. So it's giving her the options of using a better makeup rather than no makeup, because for her no makeup's not an option at all.
And I think I wouldn't reach straight for a retinoid in that situation. Either the big trouble with retinoids, as you said, they take a while to work. You're looking 12 or 26 weeks, and they're going to be frustrated and slow. So it's actually one of the best times to actually use antibiotics short term, because that will settle the acne more quickly. It actually improves your tolerance to retinoids, so you're less likely to get irritation. So by the time the retinoid's kicking in at 12 weeks, their acne is good, you stop the antibiotic and they're tolerating the retinoid for their long-term control. So I think in that situation, I think antibiotics are good in that short term.
So you're using them concurrently, both at the same time?
Yeah, so when you're starting a retinoid, often if they've got moderate or inflammatory acne, I'll start the antibiotic, an oral one, or a topical in that first 3 months.
Right, well let's go on to our next case study involving Jennifer, 30 years old, recently ceased the oral contraceptive, she wants to get pregnant. She's developed severe acne to the jaw area, mainly papulopustular, some cysts. It's red, it's inflamed, painful to touch, and she's still not having any success at conceiving. Parker.
Well, that's a description of post-adolescent hormonal acne, and coming on after ceasing the pill, and then she had irregular periods, didn't she? That you'd be quite suspicious that that may be polycystic ovaries.
What would you do for her?
In terms of her acne,
well, she's not going to go back on the pill.
Pippin?
She's not going to want to go back on the pill.
You're limited in that she's trying to get pregnant, and we'll leave aside for one moment the management of her polycystic ovarian syndrome. But her wanting to get pregnant, she can't go back on the pill. Similarly, if she is quite likely to conceive despite her subfertility there, you're not going to be wanting to use, or you're not able to use a great many of the treatments we'd use. So again, I'd be using benzoyl peroxide, salicylic acid as the topicals, and if she had to have, if she did require systemic treatment, erythromycin as the antibiotic of choice.
It's an awkward one.
And I think the other bit adding here, that this patient's not going to have sensitive skin, the female adult, especially in the lower face, you've got to have sort of a very gentle cleanser. And my favourite product actually would be combining sort of a topical antibiotic and the benzoyl peroxide to improve tolerance and safety and control.
So it's that clindamycin combo that you were talking about earlier?
Yep, so clindamycin and benzoyl peroxide either in a fixed combination, DUAC, or the two prescribed separately.
And how often do you apply that?
And the good part is with the fixed combination, it works better than twice a day of the individual product, so it's just once a day. Generally I'll do it an hour before bed so they don't rub it on their clothes, on all the bedding and that, so they'll have less trouble with bleaching. But that once a day is usually quite practical, and spot treatment if required with the same product.
John Bell?
Yes, I agree. I think that's the most appropriate treatment. We talked earlier about the oral antibiotic if necessary, but certainly in the first instance the DUAC type formulation I think is the way to go.
Susie, what would you do in general, sort of?
Well, in general, it's about nothing too harsh on the skin. So your over-the-counter products that might work for a teenage skin are going to irritate her skin no end. But most importantly, it's about she's got an awful lot going on in her life. So for us initially, it would be just in our consultation.
Let her vent.
Absolutely, yeah, unburden. And, you know, in this client, we see a lot of clients like this. They come into the clinic. very, very low self-esteem, difficulty in maintaining eye contact, a lot of frustration at why this is still happening to them, a lot of confusion about what they should be using, why they can't use what they used to be able to use on their skin. Their skin's definitely different, but most of all they feel a bit of relief at finally being able to unburden it. So it's a very, for this particular lady, it would be an exceptionally, it would be devastating.
And you've got some pictures of treatment of a woman like this.
A very, very similar client to this, yeah. Her name's Lindsay. She's a lovely client of ours.
So,
and when she came into us...
So this is the typical picture?
Look, it's to a lot of people that's not particularly severe acne. To this lady it was absolutely life-affecting. So it was, her self-esteem was very low. And through a course of treatment with her, she's virtually come full circle. For her, it was about getting her ready for her wedding, so we had a goal in mind. There she's still got a few little vascular scars there, but, you know, hardly any lesions left. So for her, a really lovely outcome. She was ready for her wedding.
Using what? That's using the light therapy?
Using a combination, good skincare advice, got onto some good makeup that was appropriate for her, and light-based therapies, yeah.
How expensive are they?
The light-based therapies can be a little bit more expensive. We usually use them as sort of a last resort. We've tried everything. This lady had been through, similar to myself, and had tried everything. So the antibiotics, over-the-counter products, and nothing had worked. Expensive, usually a course of treatment's about $800, something like that.
Really?
We usually do a course of 8 treatments over 4 weeks, so we see the client twice a week. And then after that, we usually see them once a month. It takes about 4 to 5 months to really get good control. Our aim is realistically to get to the point where our clients they get 1 or 2 pimples every now and then, 1 or 2 lesions, but other than that they've got great control.
And of course in this age group they're more likely to take on the dietary advice that Neil's suggesting as well.
They're so compliant, they're ready. Whatever you tell them to do, they'll do. They're just ready for the answer.
They don't want it anymore.
Absolutely.
Let's go to our final case study, who's Gregory, 22 years old, distant Aboriginal heritage. He lives in a remote community in southern Queensland and works part-time as a builder's labourer. He suffers from severe acne with nodular and cystic characteristics. He's had it for about 6 years. It's affecting his back, neck, face, chest, and it's left atrophic and hypertrophic scars. It really has knocked him about psychologically, and he has become really withdrawn and has never seen a dermatologist. Parker?
The dermatological part of this patient, he requires things that I can't provide for him, so he needs an urgent referral to a dermatologist, and I'll help deal with his psychological issues, but he needs isotretinoin.
So what are you going to do for Gregory?
Well, I think, as we sort of discussed earlier, that this sort of patient, Roaccutane, is really the treatment of choice, and especially done early.
So he lives well out of the way, country town. The dermatologist has, an 8-month waiting list. What's the GP going to do? And
I think with this patient, I think it is good to start the antibiotics, and I always like combining Roaccutane or isotretinoin with erythromycin to help prevent that bad flare. So I think if you're going to start an antibiotic, something like erythromycin is a good one to start in this gentleman, and then fast track him in to see a dermatologist. And for this sort of patient, it's the females who have most issues in prescribing isotretinoin with the pregnancy prevention and risks. For this gentleman, hopefully he's going to feel much happier as his acne goes away.
And how much are you going to be able to do for his scarring at 22?
Unfortunately, once you've got the bad scarring, particularly on the chest and trunk, our treatments aren't very effective, and time will only improve them a bit. The most important part would be to try and get this sort of patient early on, but for his face, with his scarring, we could do quite a bit to help. And
what can country GPs do if it really is difficult to get access to a dermatologist, even for an urgent case like this?
So hopefully in sort of areas where there isn't a dermatologist, there will be sort of some paediatrician or someone in the area who's quite familiar and comfortable with prescribing isotretinoin. So hopefully in most areas where there is a need, there'll be someone you can work in well with. And
of course in Queensland and some other areas you could get teledermatology.
Yep, and there's definitely a few areas where it's supported, and if you're having troubles, it's often good just to call our college to ask, who in the area could help out. Is there an outreach service? And hopefully we'll have more and more with time.
So talk me through scarring in acne.
Okay, so the big thing with scarring, prevention's the best treatment, and seeing people early or referring one to at risk of scarring. We mentioned before, people with a family history, with a severe nodular cystic acne or acne that's been quite inflamed for more than 2 years, or another group. And once you get to scars like these, so the first picture there is of the ice pick scars.
No, that's not the scar, that's the nose, is
That's
it we're
the nose.
seeing? Right, it's hard, it's like one of these quizzing, guessing games.
And I think sort of the ice pick scars, you can probably see them better on the right side next to the box scars. So the ice pick ones are the ones that are just sort of like little sharp indents in the skin. Typically you see them on the temples or cheeks, and for people where their acne hasn't been too bad, these sort of scars are often due to manipulation or picking or squeezing of pimples. So the first thing to do when you start seeing these is tell the patient not to squeeze or manipulate their pimples, and once you've got a patient who's doing that, you've got to sort of be quite aggressive in controlling their acne, and this is also sort of patient where I'll avoid any irritant topicals or anything that gets their attention to the skin. So I would be looking at sort of antibiotics initially to get control, and or maybe hormonal treatment and that there.
And what about other forms of scarring?
Okay, so with the other forms, the box scar ones are sort of like a punched out box, and these, like the ice pick scars, are some of the harder ones to treat with laser, that often they need to be sort of cut or excised before then doing laser to blend in the scars. But with these sort of more soft depressed or rolling scars where you've lost the tissue sort of collagen and elastin, it becomes a bit more lax. With time, these can sort of age more greater than surrounding skin. So often people have had bad acne when they hit 40 or 50, suddenly their face will start to sag and they suddenly feel old. So you'll get another group of people presenting worried about their scarring when they're in their mid-40s. But sort of treating those early and combining that with good sun protection can
Can you just go back to that, those pictures though, there, the hypertrophic one, just explain this, the hypertrophic one, if we just go back to that shot there.
And so with the hypertrophic scars, where you get sort of increased collagen in the area where there'd been some cystic acne before, and for those, they can be quite irritable, quite tender, and they do very well with an injection of triamcinolone or corticosteroids. And you've just got to make sure, if you are injecting these, be familiar, either get your dermatologist or other person to help out, but on the face, never use something more than 10 milligrams per mil for a very bad scar, and for a finer scar, you're looking at, say,
So let's double back and go through the management then of scarring. We obviously talked about prevention, which is most of today's programme has been about.
Yep.
But scarring, just so what are the treatment modalities? You've talked about intradermal injection of triamcinolone,
Okay.
which is for the hypertrophic.
So for the hypertrophic or fecal keloidal ones, the injections of
How often?
corticosteroids about every 4 to 6 weeks until they flatten down, and the aim is to keep going until they are completely flat to help stop them coming back. And that can be all people really want on the trunk and shoulders, because they're the uncomfortable ones or the most unsightly
And you just
ones.
raise the bleb in each lesion?
And you inject it into the solid bit, make it go just a bit white, but make sure you don't inject it into the surrounding sort of dermis or area.
Right. Okay.
But for the face, if you've got those soft, depressed or rolling scars, they're the ones which do really well with laser, and they're the people that you could recommend to go and see someone who does those sort of treatments.
Now, what kind of laser?
And these days, the fractionated lasers are sort of the main sort of standard for treating most types of acne scars. That it improves all the different types of acne scars, except for maybe the ice pick one and box car ones as much.
And is that covered?
And unfortunately, all fractionated laser is not subsidised by Medicare for acne scarring. The only laser covered is more the old-fashioned resurfacing or carbon dioxide or resurfacing erbium laser, and they do work well for the very bad or severe acne, but they have a lot more downtime. It really takes a few weeks to heal. You've got redness.
So that's really quite an aggressive peel, Susie.
Oh, essentially it is, yeah, it's resurfacing, but that's where fractionated lasers are a better option. There's less downtime for the client. You certainly do need to do a few of the treatments, but it means that their recovery is a lot better. You're at far less risk of post-inflammatory hyperpigmentation, which means we can treat clients with darker skin types as well, which previously have had some pigmentary changes with ablative resurfacing. So it's certainly opened up a whole new scope of options for us for darker skin types.
And what about
as well.
chemical peels?
Chemical peels aren't really used for scarring very effectively anymore. Again, too much risk of post-inflammatory hyperpigmentation, poor wound healing, things like that. So it's definitely something where fractionated laser seems to be the gold standard.
But how much does that cost?
It can be quite expensive. So a treatment of fractionated lasers for a full face usually is about $1,200, $1,250, something like that.
Is that one
treatment? Yeah.
Just one sitting in front of the machine?
Yep. Yep.
And how many would you need to actually? Depends how bad it is.
Depends on the extent of the scarring. Usually about 3 to 5 treatments, depending on the scarring.
So this isn't for the Gregorys of this world, your builders' labourers.
or something you could save up for.
Yeah.
So this is, this is something really to consider. Do you get a lot of patients wanting it, not being able to afford it?
Personally, I haven't had a lot of patients wanting that, but again, it depends what you're seeing.
I think John touched on a point there that the client for scarring is usually in their 40s, 30s, 40s, where it's something they've wanted to do for a long time. It's definitely affected their self-esteem. So they've got other issues as well.
And they may have a bit more disposable cash or
a little bit
some aside.
A little bit as well, but it's also the resurfacing part of it's very good for rejuvenation in the skin. So I suppose it has that added bonus in there as well.
Interesting. Look, that's been fascinating. What are your take-home messages for those watching?
I think my take-home message would definitely be, as a nurse, to not underestimate the psychological impact that acne has on people. It can be quite devastating. It definitely affects every facet of your life. So to get in there early with treatment and to be an open ear for them, for sure.
Yeah.
I think my advice to the public, to the consumer out there, would be to eat a healthy diet and beware of sugary, starchy processed foods and eat more natural foods. And for the clinicians, probably two pieces of advice. It's probably worthwhile doing an oral glucose tolerance test and having their insulin measured by a laboratory to look at their insulin sensitivity level. And if it is an insulin resistance problem, involve a dietitian in your treatment.
Parker?
My message is simply like Susie's, to take it seriously. Patients with acne have significant psychological morbidity quite often, and they sometimes feel that they don't get an adequate hearing.
John Bell?
I'm going to sneak in two messages, if I might, Norman. One is, we've touched on it briefly, and that is, well, not so briefly, that is to take a good history, a good medical history. We haven't mentioned the fact that there are some drugs that can predispose towards acne, so we need to just...
Such as?
The steroids, corticosteroids, anabolic steroids, androgenic steroids, the anti-epileptics, the old ones, the barbiturates, phenytoin, isoniazid. I think even vitamin B12 can do that sometimes. So there's a range of them, and we need to be aware of those. But my main message, take-home message, is that whatever the treatment we choose, we need to make sure we have effective advice and counselling. There's no quick fix, and we need to ensure compliance. I'm going to wave a little leaflet around that most pharmacies would have. I think it's pretty good. It just reinforces the advice and counselling that I think is so necessary.
John Sullivan?
I think with acne, it really is a medical disorder with, some acute or short-term, medium-term and long-term aspects that are important in its management. That in the short term, you really want to get good control for the patient, so you're going to prevent scarring and really help them feel better about themselves. In the medium term, sort of address the other issues if they've got questions of polycystic ovaries, things such as diet, other sort of lifestyle issues. And long term, if you can prevent the scarring or manage the scarring or the psychological consequences of acne, you're going to make a big difference for these people.
Thank you very much to you all. And I hope you've got a lot out of this programme on acne. Our thanks to the Department of Health and Ageing for making the programme possible. But thanks to you for taking the time to attend and contribute and ask so many questions. If you're interested in obtaining more information about the issues raised in the programme, there are a number of resources available on the Rural Health Education Foundation's website, rhef.com.au. Don't forget to complete and send in your evaluation forms to register for CBD points. I'm Norman Swan, and I'll see you next time.